Hi, everybody. I hope you're all ready because I think we're going to just go ahead and get started. For any of you out there that I have not yet met, my name is Susan Inscore. I have the privilege of getting to work in the bone health clinic for the last 2 years after spending 32 years split between primary care and hospitalist work. I also want to let everybody know that Amanda Hunter, who's been Dr. Leota's PA for many years, is going to be next door answering questions and helping, and she may be somebody to see as you are able to come in and have an appointment. Well, let's get going. Osteoporosis, here are my objectives. We are going to talk about a lot of things. We will review how do we make the diagnosis, what are the risk factors, screening recommendations, and then we're going to spend a fair amount of time talking about how do we maximize our bone health, whether we're younger or older, how do we take good care of our bones and our body, making sure we have good nutrition, calcium, vitamin D, and maximizing our muscle strength and our balance. Most importantly, as we age, we've got to stay off that floor. So preventing falls is just as important as the fancy medications that we'll briefly talk about towards the end. And then we'll talk about how do we monitor over time to see how we're doing. So osteoporosis and osteopenia combined are incredibly prevalent. They affect 53 million American adults, and they result in 2 million fragility fractures every year. Of those, the majority are spinal or vertebral fractures, followed by wrist and hip fractures. We live in Colorado, and guess what happens when we slip on the ice? Out goes our outstretched arm. So we absolutely see a lot of wrist fractures every year. The problem with breaking a bone, in addition to the fact that it's painful and it takes away our independence, is that many patients never walk without help if they've broken their hip. 20 to 40% of patients that are elderly can die within a year of their fracture if they fracture a hip. And about a third of us, 25 to 30% of us, can lose our independence. This is an expensive illness. We are approaching $25 billion on this illness. And we think that in the next 15 to 20 years, we're going to be spending $95 billion as our population ages. Of those 2 million fragility fractures that I mentioned, 70% of those occur in women. So what is osteoporosis? It does get confused for osteoarthritis part of the time. Osteoarthritis also occurs because we're aging, but it is the wearing out of the joint space between the bones, whereas osteoporosis is a silent disease. We don't feel it. It's not painful until we break a bone. It's described as a disease that's a combination of low bone density as well as microarchitectural deterioration. The bones become more fragile and more susceptible to break. And again, vertebral, spinal fractures, wrist, hips are the most common fractures. Once we break a big bone, we have a very high risk we're going to break something else over the next 2 years. So one important thing to understand is that bone is a dynamic process. We do not have the same bones today that we had 5 or 10 years ago. We build new bone. The cells on the bottom, the blue cells, those are our osteoblasts. They're making new bone cells for us. And we also have osteoclasts. Those are the little pink cells in the divot. They're reabsorbing old bone. The problem that happens, especially as we age, is that the rate of new bone formation decreases, but the bone reabsorption continues. So again, why do we get it? We tend to get it because we're resorbing more old bone than we're making new bone. It can primarily occur due to aging, and we see most of this in women. They lose their hormones or estrogen around age 50, and they, again, are breaking down old bone at a more rapid rate. It can be genetic. It can also occur due to secondary causes. If you go through menopause before age 45, that's premature menopause. That's a risk factor. A man with prostate cancer undergoing androgen deprivation treatment. If we have times in our life where we may be malnourished, some of the medications that we take, including acid blockers, corticosteroids, can all affect our bone health. And then many of the diseases, such as rheumatoid arthritis, cancer, chronic kidney or liver disease. All of these things will affect our bone health over time. This is a list of many of the common risk factors, but look at the slide or look at the graph on the right hand of the slide, and you'll see that we achieve our peak bone mass around age 30, both men and women. But right around age 50, especially for women, there's a pretty steep level where we are losing a significant amount of bone. It generally lasts between 5 and 10 years, but we have a steep bone loss that we're unaware of. These are the risk factors: smoking, alcohol excess, simply being postmenopausal, some of our medications that we mentioned, having a family history, and then many of the diseases such as diabetes, celiac, rheumatoid arthritis, being small and thin and older. These are all risks. Being on corticosteroids, having a prior fracture, and of course, being female. This is an old Frank Netter drawing of the progression of the spinal deformity that occurs in osteoporosis. The woman all the way on the left is a 55-year-old woman who's just entered menopause a few years before. And look at the distance between her lower rib cage and the top of her pelvic bone. She's got a fair amount of space. The second image is a 65-year-old woman. The third image, a 75-year-old woman. And you can see that hump, that dowager's hump from kyphosis, from compression fractures that are occurring in the spine, and the protuberant abdomen that occurs as a response of that. And look at this, the distance between the rib cage and the pelvic bone in that final photo. There's no room between. This is what we do not want as we age. We'd like to prevent it. Bone strength is determinant on our bone density as well as our bone quality. We measure bone density in this country doing DEXA. Many of you have had many bone density tests over the years. DEXA uses something called dual photon absorptiometry. There's minimal radiation associated with it, and it is our gold standard for measuring density. In the past, we would tell patients, well, we can measure your density, but we're not sure what your quality is like. Obviously, if you have a fragility fracture, that implies that the bone quality is compromised. But there's a new test that you guys are going to hear a fair amount of later called trabecular bone score. Trabecular bone score is a brand new software that you put into your DEXA machine. And it only looks at the lumbar spine between L1 and L4. It doesn't care if you have arthritis, but if you have a lot of hardware, it's not going to be a very good image. But it's able to look at that spine and give us a textural estimate of your bone quality. It has worked out over time, and it's very clear that patients with low trabecular bone score, low bone quality, break more bones. The normal value is greater than 1.350 and low is 1.231. And the nomenclature that you'll see on TBS is either normal. If you're above 1.350, you might have degraded bone if you're below 1.231, and you're partially degraded if you're in between those two levels. An example of normal bone on the left and osteoporotic bone on the right. So let's not wait until we get clinical features. I'll show you those later. Yes, we might get back pain if we have a vertebral fracture. We might lose height. We might have a dowager's hump, but those are all later findings. It's much better if we can get screened and determine that we have osteoporosis or we're at risk before that happens. Current recommendations are that all women get screened by age 65, men should be screened at age 70, and men and women 50 or older should get screened if they have risk factors. There's a very long list of risk factors. These are not all of them, but obviously a prior fracture, any patient taking glucocorticoids, that's the equivalent of 5 milligrams of prednisone or more for 3 months or longer. If either parent fractured a hip, if you're low body weight, if you're a smoker or drink alcohol to excess, or if you have an underlying medical condition like we've discussed. Rheumatoid arthritis, diabetes is a big risk. And then there's a whole list of secondary causes of osteoporosis, again, premature menopause, hypogonadism in a man, or androgen deprivation if you have prostate cancer, tobacco and alcohol intake, medications, chronic illnesses, obviously premature menopause, and anything that affects your GI tract or your absorption. People with malabsorption, with gastric bypass, they are all at risk because they don't absorb the nutrients they need to build new bone. So we're going to look at a DEXA example in a minute. And again, we're going to talk about T-score. T-score is the gold standard way that we have made the diagnosis of osteoporosis over the last almost 50 years. And if your T-score, which is simply how many standard deviations below normal you are, normal is comparing you to a 30-year-old. If you are minus 2.5 or lower behind that 30-year-old bone mineral density, that's the definition of osteoporosis. If you're minus 1.1 to minus 2.4, you have osteopenia or low bone mass. There's also something called FRAX. FRAX is our 10-year fracture risk, and I'll, again, spend more time explaining that to you. And then, again, there's a new test called TBS that might be included on a DEXA. In our area, as far as I'm aware, only Valley View and GMA are performing TBS. And if you have had a bone density scan in the last 6 months or so, your provider could ask the facility that performed that, if it was one of those two facilities, to add the trabecular bone score estimate, which can be calculated with you not even having to go back to the hospital or the place where you had the test. So I'm going to give you a little bit more on that. Here's an example of a DEXA report. This is a hologic machine. Generally, we're going to examine the lumbar spine. We're going to look at the femoral neck, which is where most of us break when we do have a hip fracture. And we're going to look at the total mean hip. And many facilities will add the wrist or radius. If you look at the lower corner of this example, you'll see where the bone mineral density hits, but you'll also see how that patient compares to their age-matched rivals. For instance, an 89-year-old woman may have a T-score of minus 2.5, but if she looks at how she compares to her peer group of similar age women, she might be above that expected number for age. So that tells you how you compare to your age group. And then if you look at the bottom box in the close to the center, it says T-score, and that lowest number here is minus 2.3. So in this particular example, this patient's lowest T-score at the left femoral neck is minus 2.3. That puts them in osteopenia range. But if you look up above the little lower box, the FRAX calculator is in the middle on the left, and it has two numbers. The first number estimates the 10-year risk of hip fracture, and if that number is above or at 3%, in this particular example, it's at 3.7. The number above that is major osteoporotic fracture risk in 10 years of any site. And if that number is above 20% or equal to, and in this situation is at 20%. So this patient has osteoporosis based on the FRAX calculator with an increased 10-year risk of both hip and any fracture, despite the fact that the T-score is in the osteopenia range. Once again, this is an example of how bone mineral density can measure just the density, but not necessarily the strength. Trabecular bone score allows us to get an indirect measure of both the architecture and strength. This is a great slide. I like this slide because it gives you a good example on the left of an image of a bone mineral density done on, I think that's a GE lunar machine. Again, we're going to look at the spine and the hips. So this is a particular patient, two different patients that have the exact same T-score on the left based on their DEXA images of the spine. So say their T-score was minus 2.5, both upper and lower. On the right-hand side, we see the TBS or trabecular bone score. And with the top example, the TBS is 1.457. That's above our 1.350 of normal. So this patient has osteoporosis by T-score, but a normal TBS or trabecular bone score. This patient's fracture risk is significantly lower than the patient below. that TBS 1.132 is below the cutoff of 1.231. And in the center, you can see a picture of what that microarchitecture might look like. And I've told patients in the clinic for years that a 55-year-old patient with a T-score of minus 2.5 has a very different risk of fracturing than an 85-year-old with a T-score of minus 2.5. And this gives you a good example of how that might occur. So the indications for doing trabecular bone score, diabetes is a good indication because a lot of patients with both type 1 and type 2 diabetes have poor bone quality, but not necessarily poor bone density. They are at higher risk for fracturing. So that might be important in that indication. Patients with secondary causes of osteoporosis. There's some talk about using TBS to see how patients might respond to what we call anabolic drugs. Those are drugs that actually build new bone. It's not yet clear. It's a new enough test that we don't quite know how we're going to use it in that indication. But it could be helpful for the patient with osteopenia. I find it very helpful looking at it in terms of treatment threshold, as well as preoperative management. It's really helpful to help a patient understand what their preoperative risk might be with this information. It's not useful for anything other than looking at the spine. And TBS does not care if you have osteoarthritis, but it's not great if you have hardware in your back. So it's only for spine. If your body mass index is over 37, if you're morbidly obese, it's not recommended. And if you're under age 40. It can be infrequently used for patients with normal bone density, but I would say primarily in the setting of fractures that are unexplained. And again, people have talked about it not being useful for monitoring on drugs, not being useful for deciding who to treat in and of itself, but added to all those other factors that we looked at, it can be quite helpful. Again, these are the clinical features. We do not want to wait to get a broken spine. We do not want to wait to get a dowager's hump. We do not want to fracture our spine or wrist or humerus or pelvis. We would like to know before those fractures happen. So who needs treatment and who needs, we'll talk about screening too. Treatment is for anybody who has a fracture after age 50. If your T-score is less than or equal to minus 2.5, if your 10-year fracture risk at your hip is above 10% or above 20% for any site, and again, trabecular bone score might be helpful if you're on the fence about whether or not that patient needs treatment. And again, I find it very helpful for preoperative. More and more surgeons are sending patients for bone health evaluation prior to surgery. It makes great sense. The worst thing that can happen is to go through a big operation and find out that the screws are not going to hold or the bone is not going to hold. This is how FRAX is calculated. Now, FRAX is actually in the DEXA machine, and the technician who performs your DEXA will ask questions and then input those answers into the DEXA machine. But you have to be asked the correct answers or questions, and you have to put the right answers into the machine to get the right answer out. So again, basically, it's looking at our age. Have we had a prior fracture? Has either parent fractured a hip? Are we taking prednisone daily? Are we smoking? Are we drinking too much alcohol? Do we have rheumatoid arthritis? Multiple sclerosis and diabetes can also be put in that category. And then number 10 is secondary causes of osteoporosis. That would include things like premature menopause, severe vitamin D deficiency, hyperparathyroidism, Graves' disease. There's a lot of things that might be under that secondary cause. And then if you have the femoral neck density, you put it in, but you can actually calculate FRAX without having that femoral neck bone density if you don't have it or you don't know it. So whether we are a patient who finds out that we have osteopenia or osteoporosis, or whether we're a younger patient in our 40s or 50s simply trying to maximize our bone health, how do we do that? What's the recipe? Number one, to me, is good nutrition. We need to eat well, and I'm going to give you more detail about that. Many patients have many questions about the benefits of things like vitamin K1 and vitamin K2 and boron and zinc and manganese and all these more minor factors. The truth is that most of the studies either haven't shown a benefit or have been sort of inconclusive. And the experts have said, eat a wide variety of good foods, fruits, vegetables, healthy grains, healthy proteins, and you don't necessarily need to take your bone supplement. We do need to get calcium and vitamin D, and I'll give you a lot more detail about that. We need to exercise because muscles and bones are doing the same thing. If a muscle is getting weaker or we're losing a lot of weight and we're losing a lot of muscle, we're going to be losing bone at the same time. If we're getting stronger and we're watching a muscle get stronger, we can assume that bone is following behind. And the other thing to do to maximize our bone health is if we are a candidate to be on medication, then sometimes, as I say to patients, we have to just jump in the pool and do it. We have to do the right thing. No question that pharmacologic treatment reduces fracture risk. So again, who deserves treatment? Patients over 50 with a recent fracture. We've gone through these numbers a couple of times, but they're here again. And then what do we do when we see you in the bone health clinic? Well, we're going to take a thorough history to evaluate your risk for fracture. We're going to do certain labs if they haven't been done previously. We're going to look at your DEXA. We might recalculate your FRAX. If another test is needed, like a trabecular bone score, we would request that. We're going to talk about treatment options. We're going to work hard on getting insurance authorization, which I have to tell you is one of the biggest roadblocks to appropriately treating patients with this disease. One thing that should be in here is we're going to communicate well with your primary care provider. We're a team. We're going to work with all of the people caring for you, your surgeon, your primary care provider, whoever else is on your team. We're going to initiate treatment if it's appropriate. We're going to talk about it. We're going to get you through it. We're going to teach you everything you need to know and help you if there are problems. And then we're going to monitor along the way to see how we do. Again, we're going to do a history and physical. We're looking for anything that might imply malabsorption, any GI symptoms. I've seen a lot of people lately with SIBO, and they're worried about their bone health. Anything that affects our menstrual history or our hormone levels, as women or men, can affect our bones. And again, we're going to ask about smoking and alcohol, kidney, liver. We're going to look at your medications. We're going to order appropriate tests. We talked about DEXA. We talked about FRAX, TBS. VFA stands for Vertebral Fracture Assessment. It uses DEXA. All these things use DEXA. It takes a lateral image of your spine. It gives pretty good images from about the mid-thoracic spine down to L4. Again, with minimal radiation exposure and minimal cost, you can look for a, quote, silent compression fracture. So VFA is indicated for patients that have lost more than 1.5 inches of height because knowing that a patient may have had a fracture may well change your treatment plan. We're going to look at labs, the basic labs, but we're almost always going to add a 25 hydroxyvitamin D level, a parathyroid hormone. We look at magnesium and phosphorus. And one of the most important tests is our 24-hour urine calcium. Our kidneys are smart. They know how to regulate calcium. So when you do a 24-hour urine calcium and it's undetectable, your body is sensing there's not enough calcium here. I can't let any calcium out through the kidney. I'm going to hold all of it. That probably also means you're borrowing calcium from your bones to hold your serum calcium level. In addition, we might see a high urine calcium level. That's telling us that the kidneys, again, are seeing more calcium than they need. They're dumping it. Let's adjust things. We don't want to overdo calcium or D, and we'll talk about that a little later. And then there are other tests. There's a lot of tests that can be done. We might do bone turnover markers to monitor how you're doing on therapy, and we might look for other things based on your symptoms. So I want to introduce you to some other team members. Many of you may know Amanda on the left because she's worked with Dr. Leota for a very long time. And if you've had a shoulder procedure or been seen in the clinic, you may know her. She will continue to work with Dr. Leota, but she's going to spend half the time doing bone health. That's going to help a lot to get more patients in and to really shorten that waiting list. And then Jessica, some of you already know her. She's a physical therapist that works at Valley View who's quite interested in osteoporosis and bone health. And she's happy to see patients. She has added to our bone health playbook and given us exercise recommendations. And she's, again, happy to do consultations for patients. We talked about nutrition. We need fruits and vegetables, healthy grains. As I say to people, our grocery cart should be full of real food, not boxes and cans, if we can help it. We should concentrate on decreasing salt in our diet because it can pull calcium from our bones. And we really do not want to be underweight or lose too much weight. If we're smoking or drinking, we need to work on changing those things as there's such a big risk. When I see women, especially in their 50s and 60s with multiple fractures, these are common themes that I see. Calcium. So calcium is complicated because we become more concerned about the possible risks of taking too many calcium supplements. However, we're supposed to get 1,200 milligrams of elemental calcium once we're over 50, and the average diet probably supplies about half of that. So I spend a fair amount of time educating patients about the other places that they can find calcium. The absolute best way to get our calcium is in our diet. We can't always do it, but if we can get all of our calcium in our diet, we don't have to worry about our kidney stone risk or our atherosclerosis risk. Patients are sometimes being told by their cardiologist or their neurologist, because they've had either a heart attack or a stroke, that they should avoid calcium supplements. So caution when it comes to calcium, we should not take more than 1,000 milligrams of calcium a day, and we should attempt to get it from our diet. Vitamin D, we need vitamin D to absorb calcium. And I think 20 years ago, many of us were unaware of that recommendation, and about 40% of the population is deficient. But we become smarter about vitamin D, but we also, I think, as humans, sometimes try to overdo it. I see more patients with high or borderline high vitamin D levels than I used to. And I also see a lot of patients with a history of osteoporosis being told to take 125 micrograms or 5,000 international units of vitamin D daily. That might be needed for somebody who can absorb it normally, but it's going to require monitoring and following so that you don't get too high. Vitamin D can cause toxicity and all kinds of other issues. So most of us need 1,000, sometimes 2,000 units a day, but we rarely need 5,000. And a group came out a year ago with a consensus of that we will not become toxic on vitamin D if we take 4,000 IUs or lower. So that has become sort of the maximum dose. 4,000 IUs is equal to 100 micrograms. Again, we're always going to do a level, and you do not get benefits from a vitamin D level that's 80, 90, or 100. You want to be in the mid 30s to mid 40s, maybe up to 60. There is some data in cancer patients, but they rarely recommend levels higher than 60. Here's what we need in our grocery cart. Lots of healthy foods. Not all of us get to have these healthy foods, but this is what we need to be doing. There's a fair amount of calcium. We know about milk, we know about cheese and yogurts generally, but lots of people are not consuming milk products. Lots of folks, especially in our valley, may be vegan or vegetarian, so they have to work harder to get their calcium from their greens, from their beans, their lentils, many of the grains. Amaranth is always discussed, but oatmeal has 100 milligrams in a cup, and many of the fruits and the vegetables that we eat. Salmon, sardines, partly because of the bones. Nuts have calcium. Almonds are the highest containing. Whey protein, someone asked a question earlier about whey protein. Whey protein has calcium in it. So when we get calcium from our diet, it doesn't hurt us. Our body handles it appropriately. Exercise, exercise. It doesn't matter if you're 35 and a marathoner. It doesn't matter if you're 95 in a wheelchair. We have to do what our body will allow us to do. So we're going to push patients to work on upper body strength, on core strength, on muscle strengthening, aerobic work, because again, muscles and bones work together. You can't have one without the other. So we're going to push patients to achieve their maximum goal, possibly with a physical therapist or a trainer guiding them, because we do not want to go out there and hurt ourselves or overdo it. Balance and posture. Tai Chi and yoga and Pilates and all of the things that you do on the mat, these are all important. Standing at the sink, brushing your teeth, standing on one foot and switching sides, it's all important. So take every opportunity that you can to practice your balance. Some people have told me that in Europe, some older patients try to get off the floor every single day. You want to make sure somebody's with you just in case you can't do that, but it does make sense as we age to make sure that when we do fall, we can get up. I borrowed this from Jessica, use it or lose it. Again, it's just as important. There's lots of data, lots of studies showing us that muscle strengthening, balance work prevents fractures. These are some things that we need to do, especially if we learn that we have osteoporosis. We need to take an inventory of our home. We need to look around to figure out what's going to trip us, what's going to make us fall. We need a night light if we're going to get up and go to the bathroom in the middle of the night and the stairs are 2 feet away. We need to make sure our hearing and our vision are as good as we can get them. And again, we need to strengthen our body. Lots of people that are supposed to walk with a cane and walker don't do it, but it can keep us from falling. When medications are used, we put the 2 medication groups into categories of anti-resorptive and anabolic drugs. Anti-resorptive drugs are the classic drugs that many of us have used over the years. Anabolic drugs build new bone, actually lay down new bone cells. Anti-resorptive drugs prevent reabsorption of old bone with the hope that your body can build new bone. Hormone therapy and anti-estrogen SERMs are the mildest anti-resorptive drugs. Alendronate, Fosamax, for people with indigestion or GI side effects, reclassed as the IV form. Bisphosphonates get incorporated into your bone. They should be used for about 5 years, and then we should walk away from them for a while. Because they're incorporated into our bones, it may take us a year or 2 years to get them out of our system to a point where we need treatment again once we've taken our 5 years worth. This will also reduce osteonecrosis of the jaw risk and atypical femur fracture risk. Both of those can occur with any drug that has anti-resorptive effect, except hormones. I'm not aware of it occurring there. But bisphosphonates, denosumab, and even romosozumab, Avinity, can very rarely, 1 in 10,000, cause osteonecrosis of the jaw or atypical femur fractures. Prolia is our final anti-resorptive drug, and it can be used at least 10 years. There continues to be a response to denosumab or Prolia year after year, at least to 10 years or longer, unlike the bisphosphonates, which again, we should use them for 5 years. We might come back to them 2 or 3 years down the road, but we take a break. We would almost never be on a holiday or a break with Prolia because about a month after we should have gotten our last 6-month shot, it's completely out of our system. And there's a risk of rapid bone loss and fracture for patients that have been on Prolia for a period of time and then stop it. So Prolia, I think, means fair commitment to saying, I'm going to stick with this. And if it disagrees with me or I don't want to take it anymore, I probably need to transition to a different medication. I hope I answered another question out there from earlier. This is a picture of the anabolic drugs. And, if we had all the resources available to us, we would just use anabolic drugs. We would just build new bone and not worry about the milder drugs that have scarier side effects. But they're either costly or they're only used for short periods of time. So the parathyroid hormone analogs, Tymlos, as well as Forteo, that includes that's teriparatide and abaloparatide. They've been around for 20 plus years, at least Forteo has, but they're very costly. You have to fill them at the pharmacy. There's a daily injection involved. Pharmacies and insurance companies are getting better and better and better at paying for these medicines. So if this is that medication, the parathyroid analogs, they are pure anabolics. They will never cause osteonecrosis of the jaw in a patient who's most worried about their dental health. That's the best way to go. Avinity is an interesting drug because it has combination effect. It does work as an anabolic drug, and in fact, you will see larger increases in bone density with Avinity. But the second half of the year that you're on it, Avinity is given as 2 monthly injections for 1 year, so 12 injections in a year. The second 6 months, it acts more as an anti-resorptive drug. And just like the anti-resorptive drugs in the 2 studies of Avinity that included over 11,000 women, they saw about what we would expect with ONJ and atypical femur fractures. They saw 2 episodes of ONJ and 1 atypical femur fracture. So they occur about 1 in 10,000. unless you take a bisphosphonate for a long time, and then the risk goes up to 1 in 1,000. Again, many of the medications that we're used to using are so-called maintenance medicines, not to say that we won't have an increase in our bone density. Many people do, especially early on, but if they simply hold our bone density or hold what we gained with that anabolic bone building drug, that's success. Again, Prolia can be given 10 months or 10 years or longer, the bisphosphonates for about 5 years. That includes both the IV and the orals. Calcitonin is not used to treat osteoporosis much in this country simply because it's a very mild medication, and estrogen is appropriate either in addition to another medication or in a patient with very, very low risk who's probably younger and symptomatic with menopausal symptoms. Treatment order probably makes a difference. There is some pretty good evidence that getting an anabolic drug first has a more profound effect than if you were on an anti-resorptive drug first. That doesn't stop us, however, and I see a lot of people get a big response from an anabolic drug, even if they were on an anti-resorptive. But if we're seeing patients at the highest risk, or we're seeing a patient for preoperative evaluation, we're almost always going to pick an anabolic drug. We need a drug that's going to build new bone as quickly as we can. And remember that pharmacologic treatment reduces fracture risk, somewhere between 20% on the lowest side with hormone therapy, all the way up to 70%, and maybe even a little bit higher with some of these newer anabolic drugs. We monitor therapy usually by doing a follow-up DEXA. Our insurance will generally pay for a bone density 1 year after a new treatment is started. We may monitor your bone turnover markers, especially with the anti-resorptive drugs. The CTX goes down with an anti-resorptive drug. The PN1P goes up with an anabolic drug, so we can use those. One of the most important things I want to impart this evening is that osteoporosis is a lifelong disease, and we have to pay attention to it. We may or may not be on a medication all the time, but it's not an illness that we're going to get a year of treatment and, quote, be cured of. So sequence of therapy may be important. We may jump around between those two categories frequently, but we can reduce people's risk of breaking bones, and we can keep them home and independent for much longer periods of time. And then fracture risk stratification and treatment can be individualized. There's not one drug for every single person. So we really have to look at the big picture. Some people have risks or concerns or family histories that make them intolerant or just afraid of certain medications that are out there. So May is Osteoporosis Awareness and Prevention Month, and we are getting it started right May 1st. So it's Bone Health and Osteoporosis Foundation's 40th anniversary. I was on their website today just looking for information, and they have this or that address, I think, will take you to the 40 patient stories. They have support groups, and there's a ton of information. So that's usually the website that we're going to direct you to for more information. Lots of things about exercise, lots of classes that you can join, and things like that. All right, now we're ready for those questions.
All right, here we are. We've got a lot of questions for you.
No.
So get ready.
Okay.
All right, so question number one. What are your thoughts on running as exercise if you've been diagnosed with osteoporosis?
If you are a runner and that's what you've always done and you do it safely, I think you keep doing it. I think you're going to use precaution when you're running on the ice. Hitting the pavement by running doesn't necessarily increase our bone strength better than just walking. There's a lot of studies out there. So you do what your body is good at, and you maximize whatever you can do.
Great. A follow-up question about height loss. Wondering over what time frame 1.5 inch height loss would be.
I mean, it's sort of whenever you achieve your peak height. We all lose about 1 inch of height just because our discs get dried out as we age. But if we lose 1.5 inches, it doesn't always imply that we have a fracture. It could be scoliosis or something else, but that's the reason that we're going to start looking at your spine to make sure there's not a sign of vertebral fracture. So it's basically your life.
Right. Can women go back on hormone replacement therapy after being off? Let's say that this specific person was wondering, 67 years old, off for a year, can they restart?
You can, but you will have a decreasing benefit from hormone therapy as you age. So, of course, the younger we are, the more open our bones are, the more amenable to the effects of hormone therapy. When we get probably 70, 75-ish, estrogen has a lesser effect as we age past that time. So what I tell women who are or 67-ish is if you're having symptoms that would require a daily estrogen supplementation with or without progesterone based on whether you have a uterus, then that's a decision you're going to have with your provider. I do occasionally put women in that age group on hormone therapy, but it's almost never going to be our primary treatment. It's going to be additive. There's lots of studies saying if you're on estrogen and alendronate or Fosamax, there might be some additive effect. It would rarely be your primary treatment, but there's no question that women who maintain estrogen supplementation. I had a patient who lived to be 98. Her daughter was an OBGYN doctor in Washington, and her daughter was determined that her mother was going to stay on hormone therapy. And that was in the midst of the Women's Health Initiative coming out, and this entire country came off hormone therapy about that time. But her daughter said, estrogen is good, Mom. You're going to take it. We're not going to worry about the side effects. And that woman lived to be 98 with no fractures. And her bone density was higher than you would expect. But again, that was a lifelong of estrogen. So you really have to weigh the risks and the benefits, I think, with your provider.
A couple questions about Pilates and yoga. Wondering if there are specific exercises that aren't great for osteoporosis
with
patients.
Yeah, with spine, I always tell people sort of the same precautions they tell you when you have back surgery or spinal fusion. Be careful about bending, lifting, and twisting. And those are all true with yoga. It's not uncommon that people with severe osteoporosis at high risk for vertebral fractures have done a twist or a move that's occasionally resulted in a fracture. Pardon. But a friend can come and give you a big hug and occasionally cause the same problem. So we have to use caution. And I think, again, with those sorts of moves, it might be helpful to have somebody like Jessica who's trained in osteoporosis prevention, but you just want to use caution when you're doing some of those moves. And you may not do all the moves. You may do 10 or 15 that feel like they're not going to hurt anything.
A couple questions about calcium. So wondering what the best type of calcium is, and then another question related, wondering if a person feels like they get enough calcium through their diet, should they supplement anyways, just in case, or how do they know that they're getting enough?
Right. So again, if you believe you're getting all your calcium from your diet, you simply do a 24-hour urine calcium test. It's not simple to perform because you really do have to collect all of your urine over a 24-hour span of time. But your provider can order it. It's not a terribly expensive test. And we tell people that a normal 24-hour urine calcium can be anywhere between about 70 and 300. And, quote, ideal for bone health is felt to be above 100 and up to about 200, 250. So I tell people, if you think you can do it with your diet, which is ideal, do your 24-hour urine calcium with your diet. If the number is too low, we would add a supplement and consider rechecking it.
Okay, so for patients who are
and the best, I'm sorry, the first part of that was the best form of calcium. There is no perfect answer to this, except that many, many years ago, they studied swallowable calcium supplements versus chewable calcium supplements. And there was no question that the chewable calcium supplements were absorbed better. We know that dietary calcium, because it's bound pretty quickly in our body, causes less trouble, for instance, with kidney stones. So in my tiny little mind, my belief is that a chewable calcium, probably taken with food in our stomach, calcium carbonate is the most effective. We get about 40% of it is bioavailable. So for instance, Tums Ultra is 1,000 milligrams of calcium carbonate, but you're only getting 40% of that. So a Tums Ultra has 400 milligrams of elemental calcium. But calcium carbonate, which you get more of, can be harder on your GI tract. So if you get gas or bloating or diarrhea or constipation, or you're taking an acid blocker, calcium citrate might be a better calcium for you, even though we might only absorb 27% of it. But it'll be easier to tolerate. So what I would say is dietary is the best. If you think you're doing that already, get your urine sample and see how you do. And if you feel like you need to add something, probably a chewable calcium with food in our stomach is the safest way. And we'll only absorb 600 milligrams of calcium at any given time, no matter how much we take. So if we absolutely need more than that, we're going to split it up.
All right. So for patients who are at risk for breast cancer, wondering if raloxifene can help build bone density.
Absolutely. Raloxifene was studied a long time ago with the Moore study. And the interesting thing about raloxifene, and that it was the one study they did there, there's a STAR study that actually compared it to tamoxifen. Most people with breast cancer have heard of tamoxifen. Raloxifene and tamoxifen have very similar rates of breast cancer prevention, about 50%. I tell every woman that raloxifene is an option if she has a strong family history of breast cancer. And again, that might be in addition to another medication, that might not. Raloxifene will increase bone density up to 1% and reduce fracture risk about 30%. So again, it's on the mildest side of the medications, but I think it's worth discussing. Now, I cannot, other than Bill Robinson at the university, I have not found an oncologist that is recommending raloxifene, and it's because they have reams and reams and reams of data with tamoxifen. However, tamoxifen can cause uterine cancer. Raloxifene does not. So if it were me, I would prefer raloxifene, even though there's one head-to-head study, because it will not cause uterine cancer and seems to have the exact same prevention. There's a newer drug, it's more expensive, that combines raloxifene with estrogen, but it's a costly medication, but it's another SERM.
So once someone has been on Prolia for 10 years, then what?
It's a hard decision. It's not entirely clear because, again, we want to individualize treatment to that person. If you've been on Prolia for 10 years and you've never had a problem or a side effect, I would look at what other medications you've been on. I would look at what fractures you had had and whether or not it would be worth transitioning to an anabolic drug, especially if you had never been on one and you still have risk. You could certainly take a year or 2 years of an anabolic drug and come back to Prolia, just like you can go back and forth between the bisphosphonates. So if you've completed 10 years of Prolia, an option might be to transition to an anabolic drug. It might also be to get reclassed every 1.5 to 2 years for 3 doses. That's the IV bisphosphonate. And a lot of the osteoporosis experts prefer that because it's such an infrequent dose. We don't have to make sure that you're remembering to take your medicine, and the side effects, other than the very first dose, are much less than with taking an oral bisphosphonate.
Great. Okay, let's see here. One person's wondering about how to minimize the risks of osteonecrosis of the jaw and atypical femur fractures.
Right. So minimizing those risks, the most important thing is to not be on bisphosphonates more than 5 years at a time, I would say. And most of the cases of ONJ have occurred with bisphosphonates. The other thing that you can do is, well, we tell everybody before you start treatment, you want to make sure a dentist has looked at you, that you don't have any plans for upcoming surgeries or procedures. A minor cleaning, a minor filling isn't going to cause trouble, but if you need an implant and a bone graft and a lot of teeth pulled and you need to heal, you would like to do all of those things before you take an anti-resorptive drug. If you're already on an anti-resorptive drug and you need dental work, if your medication is Prolia, in theory, you could wait until the Prolia is due at your 6-month appointment, not get it, get a CTX level, and try to make sure that that number wasn't completely suppressed. A lot of times on anti-resorptives, that CTX bone turnover marker will be low. A normal range is somewhere between 100, 150, and 1,000. Sometimes it's 72 or just undetectable. You kind of want that number to come up a little bit, at least into the 100 or 200 range, if you can, before you do dental work. If you're already on a bisphosphonate, again, it's in your bone. There's no simple, easy way to stop it and get dental work and come back. So you do the best you can. With atypical femur fractures, there are a few signs. I was reading a lot of things about how people are using a bone density to look at the place where people rarely crack. The good news about atypical femur fractures is that if you limit bisphosphonates to 5 years or less, you almost never see it. And even when you do see it with an anti-resorptive, it occurs in 1 in 10,000 people. It's a terrible complication, but I don't think anybody has figured out a way to prevent them other than, again, you could adjust medicines with dental work, but no known way to reduce the risk for atypical femur fractures that we know of.
One person's wondering if you can get a trabecular bone score if you have a L2 to 4 fusion.
I don't think so. The hardware, it's not the arthritis part, because a lot of us have a lot of arthritis in our spine, even to the point where that bone density place is no longer scanning our spine because it's so arthritic. The TBS doesn't care about arthritis, but hardware is going to probably make it inaccurate. And you really need L1 through L4 to get a good number. So this is relatively new to us, but my understanding is that hardware means we probably can't have a TBS.
Someone's wondering about algae-cal. They've heard that there are studies out there that say that it builds bone just as well as the medications with less side effects.
I mean, I tell patients, maybe there's a perfect calcium. The experts never talk about the perfect calcium in all the many years of conferences I've been going to. Again, dietary is the best way to get it. Lots of people are taking algae-cal. I don't have anything from the bone density experts saying that's appropriate, but again, you may absorb it better. There's a lot of calciums that are absorbed better. Swallowing a solid pill is the least probably best way to absorb calcium. But again, what I do is I get that 24-hour urine calcium as long as I can talk the patient into it. And if you're right where you need to be, whatever you're doing is working and it's perfect. Whether it's dietary, whether it's algae-cal, whether it's a gummy or a chocolate or just your diet.
All right. So I think we'll do a couple more questions live, and then we can answer some questions via email as well. Okay. Wondering, how late is too late to start hormone replacement therapy? If someone's 57, 67, and they haven't done it before.
Yeah. Again, I would say that at 75, it probably makes no difference to speak of. And the closer we are to that age, the closer we are to 50 or 55, probably the more benefit that we're going to see. And again, you have to weigh what is your risk of breast cancer, what's your heart attack and stroke risk, what's your blood clot risk. Topical estrogens, either in a patch form or a cream form, do not seem to have the same vascular risks that a systemic pill does. And if we have a uterus, we need estrogen and progesterone, and we need somebody to be able to manage those things. I think when we do take hormone therapy, if we're still sexually active, we're going to probably want some vaginal estrogen. And one way to get regular estrogen is to use a vaginal cream. But you also have to be able to discuss that with your provider to make sure they're on the same page as you. Some patients might do a coronary calcium score to determine their cardiac risk, so to speak, before they might indicate that or add that. Most people are not going to recommend that as first line unless you have symptomatic menopause.
All right, last question is about Prolia. Mm-hmm. So this person specifically has a lot of sensitivities to medications and allergies, and was recommended to start Prolia, is a little concerned if they have side effects. Is it safe for them to stop after one dose?
Yes. Having one dose of, we certainly worry about people who've been on Prolia, especially for a couple of years, and then stop it. Getting one dose of Prolia and stopping it because you have a side effect is not going to cause you to have some major, huge decline in your bone density because you got one dose. It's for people that have been on it probably for 2 years or longer. So anybody who has a side effect on a drug that we're not going to re-expose them to, it is important when you get bisphosphonates, when you get Prolia, and when you get Avinity to maximize your calcium levels if you can just before getting the drugs, because a lot of the side effects, aches and pains and bone aches, seem to be caused by low calcium levels, which can happen with any one of those drugs.
Great. Okay. I think we'll stop the questions there. We will, if anybody is sending more questions in now, we'll reply through the thread, and we can also reply to you via email if we don't catch you in the Q&A thread. And then just a reminder, the webinar was recorded, and tomorrow evening you will get a link to the recording of the webinar. So feel free to watch again or share with anyone that you think may be interested. And then our next event is June 5th, and Dr. George will be talking about a topic to be determined.
BBD. Thank you all for joining. It was good to see you. Thanks, Amanda and Maggie, for helping.